Good afternoon, everyone. Thank you, Dr. Jasuja and team for giving me opportunity to present. So, as we know, currently osimertinib is indicated in adjuvant and metastatic setting with the exon 19 deletion and exon 21 L85R, and also it is also indicated for EGFR T790M mutation. So, in short we'll discuss how the resistance to osimertinib develops. So, every TK, the first or second, third generation, will get the good clinical response, substantial improvement in PFS. In most of clinical trials has proven, but definitely at some time they will have the resistance. So this resistance can be due to the development of secondary mutation in EGFR receptor as primary. The first and second generation, they have the mutation of T790M. Like same on the osimertinib, they can develop another EGFR mutation, alternative EGFR pathway transformation or duplication of amplification of EGFR, and the phenotypic transformation to the small cell. This is also the mechanism. So as we know, any targeted therapy, they develop the resistance on target and off target mechanism. So on target is the alteration of the drug target, that the drug will act on drug will bind, but it will not act due to some other mutations or downstream change in the pathway. Off target, in spite of the drug will not off target is other mechanism, like they can have the bypass mechanism or alternate pathway activation like a MET or the HER2 amplification. So in this slide we are showing the secondary mutation of osimertinib with the common is EGFR C79S mutation. This is the most common mutation in EGFR, but the other bypass signaling develop is the MET amplification and HER2 amplification. These are around 15% patient, and the phenotypic transformation to small cell carcinoma. So the mechanism that EGFR dependent, that's a mutation in the C79 that the cysteine change to the serine or the 79N7 position. So this will reduce the binding of the osimertinib to the site, and this will lead to the decreased efficiency. In the first line setting, the resistance observed around 7% in FLORA trial, and the second line in AURA3, they are found to be a mutation on 10 to 26%. So these mutations, these are two types, cis and trans. These are clinically important. There's the EGFR receptor, that's 790M, and C79S mutation. Both will be present on the same allele. We call it the cis. So the drug will be first and second, third generation will be totally resistant to this cis mutation, and the drug will not act. Opposite to that trans mutation, that both these mutation can be present on the different allele. Combination of first and second generation will be beneficial for the patient. So this is the same diagram shown. Another less common mutation of EGFR G796R, G796D or ES. These are the not studied much, and these are milder effect as compared to the previous mutation. So the AURA study, these patients were AURA3. It is a post osimertinib. They have seen the resistance. So all these have the 790M present pre osimertinib. So the most common mechanism on EGFR mutation is the 21%, and followed by MET amplification 19%, HER2 amplification 5%, PI3K is 5% mutation, VRAF also 3%. While in the we compared the FLORA study in the AURA3, the first line and second line mutation studies are nearly same. So MET is the most common most common mutation independent of EGFR. So during the first line, we have the 4 to 22% patient develop the MET mutation, and in second line setting, that the 15 to 30% patient can develop the MET mutation. So first line, that's a first line patient can develop MET mutation, but they can have the intact 790M. So the first we can change to the osimertinib. But in the second generation, the progression on the osimertinib, they will have the 790M loss. So MET is the activating pathway. So the MET gene, we know it is lying on the chromosome 7 and detected by gold standard FISH test. So increases gene copy will lead to the increase MET expression, increase downtime signaling, and it bypasses the EGFR pathway. So tumor will proliferate continuously in spite of EGFR blockade. So another drug developed for that is the savolitinib. So it will block the MET pathway, and the TKI pathway will be blocked by osimertinib. So same the study conducted by the on the sevotinib, it's a phase 2 trial 7 study. So this is the patient progress on the EGFR19 mutation or EL858R receiving the osimertinib. So they two groups, that osimertinib versus savolitinib plus osimertinib. So this this study showed the around 49% overall response rate, and the phase 3 study is ongoing. So another study is that ORCHID study. This is the patient who's progressed on the osimertinib. So the second line for that they have developed 3 groups. That A is the biomarker match. So they tested for the MET alteration, C79X, EGFR, ALK, MET, rate, and so they are continuing osimertinib with the other selective blocker. And the group B was the non-match. They continue biomarker non-match. So they continued. They have given the durvalumab plus PEM carbo or osimertinib with anisetumab combination. So another is the transformation to the small cell carcinoma. This is also rare phenomena occurring up to the 5 to 10% in the patient. So we know that we have seen that so many patients has developed the small cell carcinoma of lung on top of that, on the progression. So there are the 2 hypotheses that the initial presentation patient have the both components, so small cell and adenocarcinoma. With the treatment, adenocarcinoma components get treated, but at that time small cell carcinoma become dominant. And another is that they can convert into the small cell. We know that the patient progress on osimertinib, we will continue the osimertinib except when the multiple lesions are developed. So when we can change to the systemic therapy. So for take home message from my side, if the patient is progress on osimertinib, definitely we should do the liquid biopsy. If the liquid biopsy is negative, we can go. Patient is ready, so then we can go for tissue biopsy and check the other mutations with the NGS, and we will continue osimertinib with oligoprogressive disease. And if there is rapid progression or the new lesions appearing, we should look for the small cell carcinoma. Thank you.
Thank you, Dr. Kiran. Any questions from audience? Okay, thank you.